All right, so today's discussion is going to be on monkeypox, which is an infection which you've probably read about or heard about on the news. So I'd like to kind of quickly go through monkeypox, what it is, and what we need to think about when we're in the field. So, for the discussion today, we're going to talk about what is monkeypox. We're going to talk a little bit about why is it important. We're going to talk about what does it look like. So what features should you be aware of in case you come across this in the community? We're going to talk a little bit about your assessment and treatment of monkeypox, and then what do you do to stay safe? So really, from the perspective of what is monkeypox, monkeypox is a rare disease caused by a virus similar to smallpox. Smallpox is also known as variola. Smallpox was a very dangerous virus that was out there for years and has about a fatality rate of about 30%. But smallpox has essentially been eliminated across the world because of vaccinations that were distributed and applied across all the populations during the 20th century. Monkeypox is endemic in Central Africa, meaning it's there. So most cases of monkeypox that we hear about or that are known occur in Central Africa. And it's actually called monkeypox because it was first found in colonies of monkeys, hence the name. But it's not really clear where the native reservoir of this virus is. We know we find it in monkeys, we can find it in other animals coming out of Central Africa, but we don't know where it's naturally stored or where the reservoir of this virus is. Prior to this year, most of the cases of outside of Africa were linked to international travel or through imported animals. So if you look at the CDC information on monkeypox for the United States, there have been occasional cases where somebody travels to Central Africa, they have an exposure somewhere, they come back and develop the rash and they're diagnosed with monkeypox. In the early 2000s, we had an outbreak of monkeypox that was linked to domesticated or pet prairie dogs that had been stored or had been housed in breeding facilities where they were in close proximity to animals that had been recently imported from Africa. The virus jumped from those animals that were imported to the United States to the prairie dogs, and the prairie dogs were then sold or given to their owners who adopted them as pets. So in the past, it's been linked to animals coming into the United States. In 2022, the current outbreak, which started a couple months ago, we don't know where it started. We don't know where that index case is. But it does seem to be much more common in men who have sex with men, which seems to be a current means of transmission. So monkeypox can be transmitted by contact with others who have active lesions or have the virus present. It can also be exposed through respiratory means and other ways. But we're not really sure how it got started in the States this time, but it does seem to be highly associated with men who have sex with men. Where is it? I developed this slide deck probably 2 weeks ago, and when I first started putting it together, I had this map of the United States, and probably half the states were gray and not blue. Now, if you look at almost all the states except for 8 have had a case of reported monkeypox. So blue states on this map are monkeypox states. If you look at the absolute numbers, the vast majority of cases, or almost about a quarter of the cases, or a third of the cases, are in the state of New York. California is second on the list, and New York still has about 3 times as many cases as California, and Ohio's had 8 reported cases. If you look at the numbers now, or as of July 14th versus 10 days previous, the number of cases has almost tripled. So we're not sure where this is going, but there's no doubt that the number of cases has expanded. So we're going to talk about the cases that we need to know about. How are they spread? So the virus is spread in multiple ways. One way is through direct contact with infectious rash, scabs, or body fluids. I suspect this is how the cases are being spread among the men who have sex with men. So somebody's got an infection somewhere, scabbed lesion or infected body fluids. It gets onto somebody else who then they contract the disease. Respiratory secretions can also be a means of exposure. This virus is nowhere near as transmissible as COVID. but it still can be transmitted via respiratory secretions. Another common way is touching contaminated items, clothing, linens, or dressings. Keep in mind, monkeypox is similar to smallpox. One of the ways that settlers in the United States would combat the Native Americans was to take blankets and clothing, rub them in secretions and crusts from somebody who's got smallpox, and then pass them on to the Indians. The Indians had no native immunity to smallpox, so smallpox would run rampant through the Indian population and was a vehicle of death for the Indians. The viruses also can be spread via the placenta and as well as contact with an infected animal. Again, the infected animal contacts were how the last outbreak occurred in the early 2000s. We have to keep in mind the patient is infectious from the time of symptom onset until the rash has healed. So they can have symptoms for a couple of days before the rash develops. And during that period of time, they are infectious. And then they are infectious until the rash has crusted over and the crust has fallen off and the skin has reepithelialized. There's new skin on top of the old wounds. So these patients can be infectious for weeks. What constitutes an exposure? Any unprotected contact with a patient. So if you have a patient with lesions, cover the lesions, wear protective equipment on yourself, make sure you've got gloves on, and so on. You can also be exposed via respiratory secretions. So being within 6 feet of a patient during any aerosol generating procedure without mask and eye protection can constitute an exposure. The other definition or possible means of exposure would be being within 6 feet of a patient for 3 hours or more without wearing a mask. That's a long time. It's unlikely we are going to be doing that. But you need to wear a mask and a surgical mask or better. If you're using aerosol or performing aerosol generating procedures, then you probably should have an N95 on. But this is what constitutes an exposure. And if you practice good hand hygiene, if you follow droplet precautions, you will be protected. So, again, this is an organism that's spread through either contact or droplets. So following standard precautions should protect you. So what do you think about, or what should prompt you to think about this disease? What symptoms might somebody have? So, the incubation period on this is 1 to 2 weeks. So it can take 1 to 2 weeks to develop symptoms of monkeypox after exposure. Common symptoms include fever, headache, fatigue, chills, backache, and symptoms that all go along with a viral rash or viral infection. Very similar to what you might experience if you had COVID. One unique feature of this virus, particularly when you're looking at comparing monkeypox to chickenpox to smallpox, is patients with monkeypox develop very swollen lymph glands. Could be in the neck, the groin, the armpit. Excuse me. And then there's the characteristic rash, and I have slides of that that we'll see later. But again, the patient can have these other symptoms of fever, headache, body aches, and so on for days before the rash starts to pop up. So what about the rash? Well, the rash actually has multiple stages before it heals. So it starts looking one way and then gradually progresses. So, it usually starts first as a macular rash. Macular means it's flat and pigmented. It then becomes papular, meaning it becomes raised. And then it progresses to become a vesicular or blister-like. And then eventually the blisters develop cloudy fluid within them, and they become pus-filled, and they may rupture and crust. And as they dry and age, and as the patient recovers, they tend to crust over. Typically, the rash lasts 2 to 4 weeks. So, while this rash is present, the patient is infectious. So they're infectious for the entire time they have the rash in place, up to the point where the crusts fall off and there's new healing skin where the rash was. The rash typically starts first on the face, hands, and feet, and then moves central. It's called centrifugal, meaning it moves inwards. This is the direct opposite to chickenpox. Chickenpox is what you're more likely to see. Chickenpox is on the list of differential, or the differential list of what you need to consider when you see a person with rash. So, if the rash starts on the hands and feet and then moves centrally, it's more likely smallpox or monkeypox. If it starts centrally and then spreads outward, it's more likely to be chickenpox. Another thing that helps distinguish chickenpox from monkeypox is monkeypox, typically all the lesions in one place look to be about the same age. They're in the same course of development. So either it's all macular, or it's all papular, or all vesicular, or pustular. So if you have a rash on your arms, the rash seems to be in the same stage of development across the entire arm. It may be a little different age on the face versus the arm, but the areas that are affected, the common or similar areas, tend to have a rash that's in the same stage of development. Whereas chickenpox, you can have a rash that on a body part that some of it looks papular, some of it looks red, some of it looks blister-like, and some of it looks crusted over. So the rash can be in various phases of development on the same body part. The other thing that you can see on the rash for monkeypox is umbilication, meaning it looks like there's a dimple or belly button in the middle of the blister or pustule. And I have a picture of that. So that's called umbilication. Typically, chickenpox doesn't look that way. Smallpox can look umbilicated, but there hasn't been a case of smallpox in the United States for decades. Just more of a breakdown of the staging. The first lesions seem to develop on the tongue and the mouth because it can start on the face. You have this red rash that can appear on the face, the arms, and legs. That's a macular rash that can last a couple of days. Then after a couple of days, it becomes a papule, or just kind of a raised rash, and then becomes blister-like, which is a vesicle. So each of these three phases, macular, papular, vesicular, is about 1 to 2 days each. So again, there's the progression. And then they turn into pustules, and they're pus-filled blisters, and those pustules can last for 5 to 7 days. And eventually, toward the end of the second week, they start to crust and scab over, and those scabs will stay for about another week, and then they begin to fall off. And again, as long as any of these types of rashes are present, the patient is infectious. So if you see that, back off. Get your PPE on. Make sure you don't have direct skin-to-skin contact with any of the lesions. Do not touch the patient's clothing unless you have appropriate protection on, because this material is infectious. Time for some pictures. So here are the different stages of the rash. They're not necessarily in order, but if you look at the top left, that's a rash. That's somewhere between the pustular and the scab phase. If you look at it, you can see a little like belly buttons in the middle of some of those rashes. That's the umbilication. The second rash, the top left, that's more of a papule. It's a red lump. It may even starting to blister. The thumb picture that you're looking at there, that's a pustule. If you look at the top right picture, that's a rash. That's probably on the back. And then you look at the bottom left, that is a true pustule, as is the hand second from the left on the bottom. I think the second left from the bottom is a good picture. It shows there are pustules all over the wrist and hand, and they're all pus filled, and they all are in the same stage of development. The bottom right, second from the bottom right, is more of a papule, kind of a raised bump. And then the hand on the bottom right, I would consider that to be a red or a macular rash. Basically, it's pigmented and flat. If you see a rash on the palm, it's not chickenpox. From my perspective, anytime you see a rash on the palm that looks pigmented like this, you think about monkeypox, smallpox, Rocky Mountain spotted fever, something like that, or syphilis. Secondary syphilis can also look at a rash like this. If for the patients I see in the emergency department that have a palm that looks like this, the most common cause of a rash on the palm for my clinical practice is syphilis. But you also have to think about Rocky Mountain spotted fever and monkeypox. Here's a picture of a of a man who has sex with men. If you look at on the right-hand side, you can see the shaft of the penis. He's got pustules there. Several of them look like they have a belly button in the middle, and there's starting to be some scabbing and crusting. On the left-hand picture, it's not well seen, but he's got swollen lymph nodes in the right groin. That is a hallmark feature when you're trying to distinguish between chickenpox and monkeypox. Chickenpox does not typically have large, tender, swollen lymph glands in the armpit and the groin. So, it is a discriminator. Here's a quick chart, kind of a breakdown of comparing monkeypox to chickenpox and smallpox. Smallpox is there more because of, just historical interest. We have not seen any smallpox in the United States in decades, but we still see chickenpox. Chickenpox, to a large extent, has been eliminated because of the chickenpox vaccine that is now given to children. But every now and then we'll see chickenpox in a child who is unvaccinated, or occasionally a vaccinated child who has breakthrough chickenpox, but the vaccine doesn't, lessens the severity of the symptoms. But if you look at this, the fever and the symptoms for monkeypox 1 to 5 days before the rash, chickenpox 1 to 2 days before the rash, I say that's close enough. They're fairly similar. If you look at the rash, the location for monkeypox, it typically starts on the face and then spreads to the extremities before going centrally, whereas chickenpox can start on the face. Typically, those starts on the trunk and then spreads out. Again, key discriminating point is rash on the palm, monkeypox, no rash on the palm, chickenpox. So keep that in mind. And then the other discriminator for us is swollen lymph glands suggestive of monkeypox, no swollen lymph glands suggestive of chickenpox. Time between catching it and symptoms, or between exposure to symptoms, 5 to 21 days for monkeypox, 10 to 21 days for chickenpox. For me, typically it averages about 14 days from time of exposure to develop symptoms, whether it's chickenpox or monkeypox. How long does it last? It lasts much longer in monkeypox than it does chickenpox. Chickenpox is inconvenient, uncomfortable. Most kids do well. They're improved and symptoms have gone 4 to 7 days after onset. Whereas again, monkeypox lasts anywhere from 2 to 4 weeks, and the patient is infectious from the time of fever onset until the lesions are all scabbed, crusts have fallen off, and new skin is developed. The death rate is 1 to 10% in monkeypox. Historically, it's up to 11%. More recently, the death rate for monkeypox is between 3 to 6%. Most patients, it's inconvenient, it's uncomfortable, it's debilitating, but they do well, they recover without complications. Chickenpox rarely has complications. The biggest at-risk population for significant complications with chickenpox is pregnant females. The risk of morbidity, mortality with chickenpox in a pregnant female is substantial, particularly if they develop chickenpox pneumonia. But chickenpox is, for all intents and purposes, is relatively benign disease because people do well and because the incidence is much less due to the vaccination of children. How do we treat this? Well, for most patients, it's supportive care. Patients can have symptoms and they can feel poorly, and they eventually get better. Currently, there's no specifically approved treatment for chickenpox, but there are some antivirals that have been approved for use with smallpox, and those medications may work for monkeypox. Who would we consider the antivirals for? Anybody who is at risk for severe disease. So probably the number one population of patients at risk for significant complications are the immunocompromised. So if somebody is being treated for cancer, somebody is on long-term steroid therapy, they are at risk for complications. They're a candidate for antivirals or other treatments. Young children are under age 8. Anybody with chronic skin conditions, atopic dermatitis or eczema, any of the other lesions like psoriasis, they are all at risk for complications of monkeypox, so they may be a candidate for antivirals. Patients who have had thermal injury, skin burns, they are at risk. Pregnant or breastfeeding women are considered higher risk. They may be candidates for antivirals. And then patients who are suffering any of the complications of monkeypox, which I'll talk about in the next slide. The bottom line is if a patient has monkeypox and is doing well, they don't need any specific treatment other than supportive care. If the patient needs antivirals, then generally we have to approach the CDC. My suspicion is if you are diagnosed with monkeypox, public health will be all over it, and access to the medications will be facilitated if they are indicated. A little bit, what are the complications? Again, historically, the fatality rate's up to 11%. More recently, the fatality rate's more like 3 to 6%. I think it's because we have more experience with it and we're better able to provide supportive care. What's probably the biggest complication that can result in somebody's demise? It's really the secondary infection. So, if you have monkeypox, it's going to be easier to get secondary infections, whether it's sepsis of any source or pneumonia. Patients with monkeypox can also develop encephalitis or inflammation of the brain by the monkeypox virus. I really don't know what the incident rate is, but it's not very high. Patients who develop a corneal infection with the monkeypox virus can lose vision. It's unclear to me whether or not they might be a future candidate for a cornea transplant, but if you get a corneal infection with monkeypox, your vision is at risk. And what we don't know is how many patients might be exposed to monkeypox, have a subclinical infection with no symptoms. So we don't know what the rate of asymptomatic infections is. So it's one of those things that we simply need to learn about. We'll probably know a lot more about complications and number of asymptomatic infections as information becomes more available regarding the current outbreak. Since we're at 1,400 cases as of yesterday, that's a whole lot greater number of cases in the United States than any other time. So we will be able to answer some of these questions better in future years. How about the vaccine? Well, there are two vaccines out there. The ACAM 2000 is a live cowpox vaccine. It's what has been used in years past to vaccinate the masses. And it's a vaccine that is live. They basically take that pitchfork-shaped needle that you see in the top right. They dip it in the vaccine and they puncture your skin 10 or 15 times in the same location. It introduces the virus into your skin. The Vaccinia vaccine, I misspelled it, is an infectious vaccine. It causes infection. It causes crusting and a lesion in the area, and that area actually is infectious, so it has to be covered so you don't pass it on to others. There's also the Jynneos, which is a non-replicating live viral vaccine. It is a subcutaneous injection, and you need 2 doses, dose now and another dose in 28 days. For the ACAM 2000, you're considered immune 2 to 4 weeks after the vaccine, typically more likely to 4 weeks after the vaccine, whereas the Jynneos, you're considered immune 2 weeks after your second dose. So we know that the previous smallpox vaccine is 85% effective against monkeypox, which is now why it's being recommended for, so it's being recommended for the outbreak. And currently, the recommendations for the vaccine are kind of limited. So the CDC is currently recommending vaccination for people who handle the virus, such as lab workers who are doing monkeypox cultures or running tests for monkeypox. And they're also recommending for people who've had a exposure, and they're recommending post-exposure vaccination within 4 days of the exposure. So let's say you're out on a run, you have a patient, they've got a funny looking rash, you don't think about monkeypox, you have to pick the patient up and with a mega mover, and you get their body secretions on you, and you're then told, well, you've probably had a monkeypox exposure. Well, the recommendation is that you receive one of these 2 vaccines within 4 days of that exposure. Reading the CDC material, it seems like the Jynneos injection is going to become the preferred vaccination. There is vaccine available, and they are ramping up production. There is no doubt that the risk of the disease is worse than the risk of the vaccine. Think about, if you elect not to be COVID vaccinated, yes, you get COVID, you'll be out for a week to 10 days. If you get monkeypox, you're going to be out for 2 to 4 weeks. So, I think the risk of the disease is worse than the vaccine. Currently, right now, again, the only recommendations for vaccination is post-exposure, or if you're working in a lab where you're handling the infectious material all the time. In terms of testing for monkeypox, basically you test the secretions. The CDC had been the only location that could do the test, but it's been announced within the past week that LabCorp is now able to do monkeypox testing, and that's going to greatly expand the access to the testing, and other reference labs are coming online. So it'll become more available if we need to do testing. How do you stay safe? And I think this is the important part. Part of it is having that high index level of suspicion. Could this patient have monkeypox? Right now, 8 cases in Ohio. A lot of other things pop up to the top of the list as something to worry about. COVID, sepsis, chickenpox. But have that high level of suspicion. Mask the patient, source control. We should be doing that now for all of our patients anyway when we're providing patient care. Wear appropriate PPE. So again, this infection is spread by contact and by droplets. So how do we protect? We put a gown on if we're going to be with the patient. We use gloves. We use eye protection. Don't touch your face with gloves. Stay away from your eyes. Wear a mask, surgical mask, or upgrade to an N95 for any aerosol generating procedures. If the patient has lesions, cover the patient. It could be as simple as putting a blanket or a sheet over the affected areas. In the back of the truck, turn on the exhaust fan, put it on high, put the HVAC on non-circulate. We should be doing this anyway because of our cautions for COVID. So, keep that in mind. And then wet cleanup using standard wipes and cleaning solutions. So, you wipe down your gurney, wipe down your surfaces of the truck, wipe down your blood pressure cuff, wipe down all your probes. Simple wet cleansing using our standard solutions will take care of this disease in terms of sanitizing our work area. So in review, monkeypox is a virus. It's the same pox as smallpox. It's treated via body fluids and in direct contact with the patient. So, whether it's the patient's clothing or the patient's body or body secretions. The rash is characteristic, and again, the key component is lymphadenopathy, swollen lymph glands. Think about that. The rash on palms and soles, that's not good. So again, it's not chickenpox if it's on the palm. It's in our population of patients, it's most likely syphilis. Rocky Mountain spotted fever is probably going to be the second most common thing, but monkeypox and smallpox gives you those palmar rashes where it may look flat or a little raised and it's pigmented. I'm not talking about somebody's got scaly skin because they got into poison ivy. We're talking about a flat pigmented rash like that picture I showed you. Vaccination is protective, but current recommendations do not include routine vaccination of all healthcare workers. That may change with time. And like all of our infectious diseases we deal with, your exposure, your risk for contracting the disease can be avoided by appropriate use of PPE. So, if you have to, make sure you got your gloves on, got your mask on. If the patient's got weeping lesions, put on a gown, protect yourself. Probably if the patient had a rash characteristic for monkeypox, I would shower and change my clothes when I got back to station, even if I use PPE. But that really depends on how close you were with the patient. All right, that's it. If you have any questions about monkeypox, feel free to talk to the infection control officer or reach out to me via this email address. Thank you.